Hi students, this is Dr. Karthikraja, Assistant Professor, Department of Orthodontics and Dentofacial Orthopaedics from Vinayaka Mission Sankaracharya Dental College, Ariyanur, Salem. In today's session, we are going to see about extraction in orthodontics. These are the contents of today's topic: introduction about extraction, the need for extraction, and the choice of teeth for extraction, which teeth is needed to be extracted for different clinical scenarios, and what is meant by balancing extraction and compensating extraction, and other factors which determine the extraction of teeth. Extraction became a basic treatment plan for each and every treatment in orthodontics to create a balanced occlusion and stable supporting structures. The two factors which determine the extraction treatment plan is age and the nature of malocclusion. If there is a severe malocclusion is there, we have to go for extraction of teeth, obviously. Next is age. It doesn't mean that we should do extraction for adult patient alone, not for the adolescent or early childhood, because in few clinical scenarios we have to go for extraction of the permanent teeth, that is serial extraction, where there is sequential extraction of the deciduous as well as permanent teeth to guide the teeth to erupt into the oral cavity. So going to the history, early days there was a controversy between extraction and non-extraction line of treatment. In early 1920, there was a very big controversy between two pioneers in orthodontics, between Edward Angle and a student, Kelvin Case. Edward Angle suggested that we should not go for extraction of the teeth to create a stable and balanced occlusion. He insisted more on transverse malocclusion, and he insisted more on expansion rather than going for extraction. Whereas Kelvin Case, his own student, states that we have to go for extraction. Instead of going for expansion, we might need extraction to create a well-balanced occlusion and stability. Later in 1940s, Charles Tweed, he insisted that he stands by Kelvin Case. He also stated that on examination of his treated cases, the cases which he has treated with extraction has a more stable and balanced occlusion when compared to non-extraction cases. This was further strengthened by the study by Biggs. He was an Australian orthodontist. He did a study on aboriginal skulls. He examined that there was a complete attrition of the occlusal and interproximal areas of the dead people's skulls. And he also stated that the extraction of teeth can be compensated by these attrition and interproximal reduction. Since the diet conception of the people has changed more enormously different from the ancient days to the modern era. Later, Prophet did a 40 years review on the finished cases. He insisted that initially there was half of the orthodontic patients are treated with the extraction in early 90s. Later on it was slowly reducing since the concentration has gone towards the soft tissue paradigm and the TMJ. So he stated that we can go for extraction, but we have to consider many factors before going for extraction. He states that we can't completely neglect extraction, but in few clinical scenarios we have to go for extraction. Next, the need for extraction. The first and foremost purpose of extraction is arch length tooth size discrepancy. It can be done by evaluating the arch length from mesial aspect of molar to the mesial aspect of the molar on the opposite side, and we have to measure the tooth size using a divider or vernier caliper. We have to assess the discrepancy between the arch length and tooth size material. If the discrepancy is more than 2.5 mm, we have to go for either first premolar or second premolar extraction. Usually, if the discrepancy is between 2.5 to 5 mm, we have to go for second premolar extraction. If it is more than 5 mm, we have to go for first premolar extraction. Next is the correction of sagittal inter-arch relationship. Mainly to mask the underlying skeletal malocclusion, we have to do extraction in either upper and lower arch. For example, in case of Angle's class 1 malocclusion, if the skeletal mal relation in the sagittal aspect is very less, we have to go for upper 4 and lower 4 extraction, considering the crowding of the teeth. That is bimax cases. As we all know, the extraction of the tooth will impair the skeletal development. So, thereby we can control the sagittal growth of the particular arch, either maxilla or mandible. In such cases, in case of Angle's class 1 molar relation with bimax proclination or crowding, we have to do extraction of upper 4 and lower 4s. In case of Angle's class 2 malocclusion, there are three scenarios. In few cases, we can go for upper 4s extraction. In some cases, we can go for upper 4s and lower 5s. In few cases, we can go for upper 4s and lower 4s. In first scenario, if the molar relation is class 2 and the patient's profile is convex with a good overjet, but the arch alignment in the lower arch is very fine, we can go for upper first premolar extraction. Thereby, we can do retraction and correct the patient's profile. In the second scenario, if the patient's profile is convex but there is molar relation is end on with mild crowning in the anterior and the upper proclination is there. We can go for upper 4 and lower 5 so that we can correct the molar relation by anchor loss in the lower arch, and thereby by extracting the upper force we can retract the upper arch, thereby correcting the convex profile. In the third scenario, if there is a crowding in upper and lower arch with the proclination in the upper arch, we have no other choice to go for all 4 extraction, that is all first premolars. In case of angles class 3 malocclusion, we usually avoid extraction in the upper arch. If there is a severe crowding, we can go for extraction. We can do extraction mainly in the lower first premolar extraction. In mild class 3 case, in few cases, that is when the incisors are in edge to edge relationship, we can go for single incisor extraction to create a proper overjet. Next is abnormal size and form of the teeth. In few clinical scenarios, we can go for extraction of the malformed teeth like macrodontia. If when you compare 2 incisors on the both right and left, if one incisor is more, predominantly more, where we cannot do build up on the adjacent teeth, we can go for extraction and replacement. If there is a dilaceration is nothing but the tooth has tipped either distally or mesially. In clinical scenarios, it cannot be moved properly within the trabecular of the bone. In such cases, we can go for extraction of the dilacerated teeth. If the crown morphology is very much abnormal, so that if we cannot do build up on the crown aspect, we can go for extraction of the teeth. Next is skeletal jaw malrelation if severe cases. In severe cases, we have to do decompensation of the underlying skeletal malocclusion. In such cases, we have to do extraction, do decompensation, and thereby we can go for jaw surgery, bi-jaw or single jaw surgery. Next is choice of teeth for extraction. The main choice depends on proper and sound diagnosis. So diagnosis plays a major role in determining the extraction of the teeth. Apart from that, it involves various other factors like age, growth pattern and its direction, arch length and tooth materials, as I mentioned earlier, profile of the patient, teeth alignment. For example, age, considering age, if the patient age is above 18, we obviously go for extraction of the teeth. It is not that we should not do extraction in the early years, but in few clinical scenarios like arch length, tooth material discrepancy, we have to go for extraction. So each and every factors are interlinked with each other. So proper diagnosis is mandatory to determine the extraction of the teeth. As we all know, the most common teeth for extraction in orthodontics is premolars, mostly first premolars and rarely second premolars. So extraction of different teeth. Usually incisor and canines are not extracted for orthodontic purpose unless until it is unfavorably impacted, it is completely blocked out. In this image you can see the laterals are completely blocked out between the centrals and the canine. When there is a congenitally missing tooth on one side, we have to go for extraction on the other side to create a balance in the occlusion so that the midline cannot be shifted. If the one tooth is totally malformed, we have to go for extraction unless until we could not able to build the crown properly. If there is a severe trauma, the neck to neck fracture on the crown, we cannot able to replace the tooth by any crown build up, we have to go for extraction of the teeth. In such cases, more prone is the upper central incisor, which is more prone for trauma and easily get injured by the traumas. Next is dilaceration. As I mentioned earlier, the dilacerated tooth will prevent the tooth movement within the bone, so that in many cases we can do extraction if there is a severe dilacerated tooth. As I mentioned earlier, in class 3 scenarios, that is mild class 3s, we can go for a single incisor, lower incisor extraction so that we can create a proper overjet and overbite. Canines. Since considering the long root of the canine, we mostly avoid extraction of the canine, but it is the most prone to get ectopically erupted because it is the last to erupt into the oral cavity. Either buccally it will impact it or palatally. In few scenarios, instead of going for extraction of premolar and bringing the canine into the arch, in few clinical scenarios we can go for extraction of the teeth. If it is so highly placed below the nasal floor like that and all, we cannot do much orthodontics to bring the canine since considering the prognosis of the canine. Most probably it will take more treatment time for orthodontics to bring the canine into the arch. In such cases, we can go for extraction of the surgical or extraction of the canines instead of going for a premolars. As I mentioned earlier, most common teeth to be extracted is premolars. In this first image, you can see there is a arch length tooth material discrepancy and the canine is erupting ectopically in the buccal aspect. So we can go for extraction of the first premolars and you can see the well aligned arch in the second image. In the second image, you can see the second premolar is impacted palatally, completely impacted, but there is a good contact between the first premolar and the molars. So that see, in these cases, if the plan is, even though the plan is first premolar extraction, we can go for the second premolars because it is totally ectopically erupted in the palatal aspect. It is a good thing to go for extraction of the second premolar instead of first premolar. Usually, the first premolar extracted in the moderate and severe cases and where there is an anchorage required. Anchorage is needed means clinical scenarios where we want the complete retraction of the anteriors in cases where we doesn't want the molars to come forward. In such cases, we can go for first premolar extraction so that we can bring the anteriors completely backward. In second premolar extraction are usually done in mild cases where we want the molar anchorage loss. For cases like in open bite, we want the molars to come mesially so that the wedge effect can be rectified and the bite can be closed. In such scenarios, if there is no much crowding or proclination in the anterior aspect, we can go for second premolar extraction so that we can mesialize the molar and correct the open bite. Apart from these scenarios, if the tooth is unfavorably impacted, as I mentioned in this image, if the second premolar is impacted completely palatal aspect and there is a good contact between the first premolar and molar, we can go for second premolar extraction. That is completely blocked out. In few cases, it will be unfavorably impacted. It can lie within the bone and there is no sign of eruption in the oral aspect. In such cases, we can go for extraction of the second premolar. Then if it is grossly decayed, if the plan is to go for all four extraction, all upper first premolars extraction, if the second premolar is grossly decayed, we can use the extraction of second premolars instead of first premolars. Next, molar extraction. First molar extraction is usually contraindicated, but it was practiced in earlier days. During the age of 8 to 9.5 years, we can go for upper first molars extraction. That is called Wilkinson extraction. The main concept of this first premolar extraction is that it is the first tooth to erupt into the oral cavity. So it is more prone to caries. So if the plan is to go for premolars, we can go for first molar extraction if it is grossly decayed, so that we can mesialize the second premolars and use the second premolars to cover up the space. So considering the grossly decayed molars, if you want the bite to be deepened, as I mentioned earlier, the wedge effect can be rectified by mesializing the second molars to the first molar region, and in case of mild crowding. But this concept is not practiced in recent days because since it is so far from the region of interest. So a maximum chief complaint will be crowding and proclination. Since the molar is the most distal tooth, we cannot use that space soon for the relief of crowding. So it is most probably rejected from extraction for an orthodontic purpose. Next is second molar extraction. The most common scenario is to prevent third molar impaction. In few clinical scenarios, we have to distalize the molars. In case of deep bite, we can go for distalization of the molars. In such cases, if there is a grossly decayed second molar, we can go for extraction of the second molar, we can do distalization of the first molar, and there is obviously there is prevention of third molar impaction. In case of second premolar impaction, in few cases there won't be a space for the second premolar to erupt. In such cases, if the second molar is grossly decayed, we can go for extraction so that we can prevent the impaction of the premolars, thereby distalizing the first molars. Next, third molars, the most commonly extracted teeth for orthognathic surgery purpose. In case of orthognathic surgery, that is severe cases, we can go for extraction of the third molar so that we can give a surgical split there. To prevent the false split, we can do extraction in the early aspect. To prevent late mandibular anterior crowding, in case of horizontally impacted third molars, we can go for extraction of third molars. Balancing extraction. Balancing extraction is nothing but removal of the tooth from the opposite side of the same arch. For example, if you are removing a tooth on the right side of your arch, first premolar, so there is a more probability of covering up of the space by the mesial tip of first second premolar and distal tip of the canine. Thereby, there is a more chance of skewing in the occlusion and thereby shifting of the midline. So to create a balance in the occlusion, if you are going for a single first premolar extraction on the one aspect, we have to do a single premolar extraction on the opposite side of the same arch. For example, in class 2 scenario, to correct the proclination, if there is a mild crowding, if the proclination is also mild, if you are planning to go for first premolar extraction, it is not correct since there is a more possibility of midline shift. So we can go for first premolar extraction on the both aspect, both right and left side. Compensating extraction is extraction of one teeth on the upper arch and extraction of the same teeth in the lower arch. If you are going for extraction of the first premolar in the upper arch, we can go for the first premolar or second premolar extraction in the lower arch. So thereby we can create a proper stable occlusion in the post-treatment. Apart from these clinical scenarios, there are certain factors to be considered for extraction of the teeth. First is the quality of the teeth. If there is a hyperplastic incisors or canine, we have to go for extraction. Next is grossly decayed. If there is a severely decayed tooth is there, we can go for extraction of the teeth so that we can replace with the natural teeth by orthodontic tooth movement or by artificial by using implant or FPD. Next is abnormal tooth form. If the size and form of the teeth are not uniform, left side tooth is little bit bigger size than compared to the right side, we have to go for extraction. If there is no possibility in reduction or the build-up in case of severely malformed tooth. Next is considering the medical history. This is the most important factor. We cannot simply advise for extraction of the teeth without considering the medical history of the patient. The patient might have cardiac problem or any bleeding disorders. In such cases, we have to get opinion from the physician whether the patient is fit to go for extraction of the teeth in spite of his cardiac problem or any bleeding disorder. So the take-home message is extraction is become a part and parcel of our orthodontic treatment, but decision to extract particular teeth should be precise and it should be taken care considering the balance and stable in the occlusion. So we cannot go simply for extraction of the teeth considering the proclination or crowding. We should think wisely which tooth to be sacrificed for the purpose of balanced occlusion. Thank you, students.